Dr. Hans. I just want to say how honored I am to have this opportunity to talk with you today. Your truly pioneering work has brought us a new tool, the Trabecular Bone Score, that can be added to the information provided by DEXA and greatly improves our insight into the health of our bones. So welcome, Dr. Hans.
Thank you. Pleasure.
Could you share with us what new information TBS will add to DEXA for people?
Okay, in a nutshell, what is important to know is DEXA have been developed primarily to measure bone density. I say primary because now we can measure body composition and other features. But primary for measuring bone density, which means the quantity of bone, while TBS or TBS Inside have been designed to measure bone texture, which is in fact related to the bone microarchitecture, which is a quality. So if I give you a slightly different light on that, just let's imagine a bar chair. Well, pretty because it's late for me, I guess, but it can be metal, or it could be plastic, or it could be wood. So what will make it strong enough for you to sit on it will be the structure of the chair itself. So meaning, for example, the little crossing and transversal bar that's holding the chair for you. If you don't have that, the chair will collapse. So the raw material is like the bone density, while the way it is structured, the little bars, for example, will be more the microarchitecture of the bone. So in fact, both are needed for you to sit on it. Without it, it will collapse. If you don't have it, then the bone will fracture, if we make the analogy with the bone.
This is the question that I really wanted to have in our interview, and that is, how did you become interested in developing the Trabecular Bone Score? What insights did you have that led you to create this new tool? And could you please tell us a little bit about your journey?
Well, I hope you have the whole day in front of you. If you read me on that, no, I tried to synthesize that. The thing is, I started working in the osteoporosis field in the early 90s. So when I did my PhD and even post-training on that and so on. So always on the diagnostic side. So at that time, still the primary diagnosis of osteoporosis beside the fracture was based on X-rays. And in order to recognize osteopenia or osteoporosis on X-rays, you needed to have at least 30% of bone loss to start to see something on the X-rays. Mm-hmm. So it was pretty vague and not very precise. So when the WHO definition of osteoporosis and the other society come along after, I was, in one hand, pretty excited because I was giving like a framework on how to define osteoporosis, and especially after with WHO definition of with a T-score and so on. Mm-hmm. But on the other hand, it's been introducing quite clearly the bone mass and also the structure, because we know since the beginning that osteoporosis is related in one hand with a decrease in bone mass, and on the other hand, a degradation of bone microarchitecture, both leading to an unacceptable risk, or the risk itself of the fracture itself, I mean. And obviously you have, I'm not talking about the consequence in terms of death, in terms of loss of dependence and so on. So all the comorbidities. So the DEXA clearly become, probably with introduction of the bisphosphonate in the early 90s, as really the gold standard to measure the density of the bone, and then all the definition is around that. But part of the definition, although important, was not fulfilled, the microstructure part of it. So that explains why about 40 to 50% of the patients who are at risk of fracture never been diagnosed, or not being diagnosed properly, or misdiagnosed to some extent, because you have some patient with, let's say, a medium level of density, let's say osteopenia, and they will fracture, while some other are osteoporotic and will not fracture. So we're missing it. There is a kind of large overlap. So having said that, that always triggers some interest for many researchers. And for why we've been using clinical risk factors, and we're still doing it, as an indirect surrogate of a structure, try to define indirectly factors that can fulfill, let's say, the BMD part of it. But for many years, a lot of researchers have been trying to find the method just to measure bone microstructure in clinical routine. So I've been trying myself to work on quantitative ultrasound for more than 10 years. So we believe at one point that quantitative ultrasound at the heel or the radius or the fingers or tibia and so on could potentially give that information. Unfortunately, it was not the case, still strongly correlated to bone density. And therefore, we couldn't use that as a complementary tool just to merge that. And that was kind of frustrating. So obviously we had the state-of-the-art technology came out, we call micro-CT. The micro-CT can really measure the bone structure in detail. It will tell you something about the trabecular thickness, how the bone is done on the right, left side, up, down, everything. But it's just not widely accessible. It just some radiation cannot be used in clinical routine in every site. That could be really in a top and a high-end university site, and it will almost give you too much information for you to have a really simple, clear method for clinical practice. And that's a problem. So it is a complex problem because a doctor wants to have a disruptive, clinically oriented technology. So they want to be disruptive in the outcome that will really help them to improve the decision for the patient, but they don't want to be disruptive into the workflow. So they would like to have something that's very disruptive without being, disrupted in their workflow. So that's, so we have to use what we call a KISS approach. I would just use it in a keep it simple, smart, just to good information in a very simple manner that can be used by everybody. And one of my dear friends, who unfortunately passed away a couple of years, Laurent Potuot, who was really the father of TBN, came to see me in about 2004, 2005, with this great idea about leveraging what was used in geophysics to analyze the soil from a satellite image and say, can we do something with the bone? And then we start to work together, and that's the way the beginning of a long, first of all, friendship, even further compared to what was before, and then really a big adventure for us just to fine-tune these tools. And then we start to have more people around. Then we created Medimaps, and then with a whole team of researchers trying to go much step further. So the idea was really to provide a simple solution to a complex problem within few seconds, without changing the workflow and possibly without re-irradiating the patients. So everything could be done like this, and you get something that is really needed. So that gives you like overall idea of the way just it starts.
Yes, great minds work well together. My takeaway from that, yeah. So why can the information that TBS adds to DEXA be helpful in predicting our risk for fracture?
Okay, so you remember my little story about the bar chair, okay? So you need both. You need several information to have the complete pictures of what's happening at the bone level. And right now what's happening, if you use only the bone density, you can have exactly two patients with the same density, but the underlying structure can be quite different. And let me give you like an example. I like to do that with showing with my hands. So I'll see if you can see it. So you can have two bones, let's say apparently the same density, all right? But then the underlying structure will be quite different. 4 thin trabecula or 2 thick trabecula, but the density as a projection will be the same. Well, hopefully for me. So underlying structure different, same density. So that means some patients, if you have more trabecular or dispatched in the correct manner through the bone, then your bone will be more solid at ISO BMD. And that's what is very important. So that's exactly what we have with the patient. Right now, we only have the BMD information. We complete that information with how it is structured within the bone to give you a global overview of it. And the combination of the density and the structure will tell you will better profile the level of risk of your patient to who will fracture, who will not.
So, I'm sure that people listening to this are thinking, I already have trouble understanding my DEXA report. I've done some videos on how to read your DEXA report and what it means, because for normal people, it can be very confusing. And so they're probably thinking, will adding TBS report to the DEXA report make this totally confusing for me? Could you walk us through a little bit how the two are integrated in the new reports, and that it's actually easier to understand what's going on?
Actually, it's quite interesting what you're saying. First of all, it's not only happening to patients, also doctors.
Oh, that's good to know.
Yeah, well, actually, doctors cannot be expert in everything, but that would be just too good. They try to cover as much topic as they can, but there is still a million things to learn. They're learning every day, and sometimes have a very comprehensive report is not always easy if they haven't learned it properly and so on. So what we have noticed is indeed a lot of doctors been using TBS, but they were holding the result for them because they were ashamed or not quite sure how to report the result to the referring doctors. And that was quite interesting. So what we did, we decided to rethink completely the report, being myself at the hospital, talking to patients or my colleagues and so on. So try to have like a keep it simple, smart approach again, even with a report, and have a systematic approach. Okay. And the systematic approach, we combine that into one report, and then that report being now fully automatic. So that means even for the doctor, if he doesn't know how to report it, we do it for him based on international guidelines and so on, combining the DXA, the FRAC, the clinical risk factor into a comprehensive report within few seconds. And that will really help to structure the report in such a way you try to follow the mindset of the report. And for example, if I walk through for the TPS, we have mostly 6 steps. So the first things is, as for DXA, we first check the image quality. So that's true for mostly for doctors or radiologists or doctors, to be sure that it's been acquired properly, because keep in mind the garbage in, garbage out concept. If you don't have a good image, proper positioning, a bad analysis, the outcome will be bad for the patient. So the quality of the acquisition, positioning, and analysis are very important. Then after, what we'll do, we will characterize the patient in terms of structure. So we'll have a reference curve with colors, and then depending on where the patient is situated, it will be considered as a normal structure or partially degraded or severely degraded. And that gives you already a different kind of level of risk. Now, the third approach, we say, okay, we know the bone status from the DXA, we know the status from structure, let's combine it together. And then what we'll provide then is like a 3x3 tables with normal, osteopenic, osteoporotic, and normal, partially degraded. That's what I call bone health category, correspond to certain level of risk. And that will be a color mapping. It will tell you how you are situated, if you are more damaged by the density or by the structure or combination of two, give you where you are. Then the next step will be, should I be treated or not? So based on this both analyses, we'll give you the BMDT score, minimum of the spine or hip and so on, and also we'll adjust that for the structure, and we'll give you one single parameter that will tell you whether or not you below the intervention threshold, let's say minus 2.5 or minus 3, if you depending on the guidelines. Alternatively, for those who want to use the FRAX, then we'll give you the FRAX, which is taking into account the TBS structure, and we'll tell you if you're above or below the intervention thresholds.
So when we do this, you'll be able to take a report and just like walk through the pages and say, this is this part, this is this part. And also, I think it's really helpful for patients to just say, green is the good zone. Like you want to be in the green zone.
Yeah, exactly.
Because for some people, they just really, are clueless about what it means. And and they're upset and concerned. And so,
Actually, we have four colors where we combine the density and the TBS, where we say low risk of fracture, medium risk, high risk, very high risk, and you go from like a yellow, orange, or green to yellow, orange, dark red, and that gives you your level of risk. So it's really very, very intuitive. And we've been testing that again against a few doctors and patients. Because keep in mind, a lot of DEXA report being done by radiologists.
right.
And radiologists may not know all the things about osteoporosis. They will provide a diagnostic based on imaging. So we also need to make it obvious for the radiologist and also for the referring doctors that will need to explain that to his patients.
Right. Interesting. So where is TBS available now? I know most of our audience are in the US or in the UK, some in Australia and New Zealand. Is TBS readily available in these areas?
Actually, as today, TBS is available in more than 60 countries around the world. So it doesn't mean very actively. So some countries just been starting and so on, but it's more than 60 countries. However, the newest report just been available actually there is a commercial release as we speak. It was today on June 22nd. It been as a release in 20 more countries with a new report, and then more to come. So it's currently already in Argentina, Austria, Belgium, Brazil, Chile, Colombia, in Europe, also United States, of course, Canada, and so many, UK, obviously, and some Japan. We have lots. So roughly right now, there is a bit more than 2,500 software installed in different places. So it's a lot, and it's not a lot. Still a lot of room for improvement, and hopefully be more and more in the coming months and years.
So we'll try to provide a link to people watching this so that they can find a center that's offering TBS in their area.
Yeah.
So obviously the benefits of adding TBS to a DEXA score are being increasingly understood in the medical community. Could you share your thoughts on this? Doctors are becoming more receptive, and so patients can ask them about it.
Yeah, actually, it's interesting because, well, I'm mostly at the hospital, so I never thought about, let's say, the go-to-market aspect of technology. So TBS is kind of a spin out from university to some extent. So it's quite interesting to see also the other side. And right now, what was very, very important for me working at the hospital is that before reach the market, it need to be fully technically and clinically validated before offering that to patients. So I didn't want to have a company just selling it where it's not validated, because for me, the importance of the patient is key. So everything is from the patient to an ID to a solution to the doctor. But having said that, so now there is more than 600 publications and numerous guidelines around the world. But it's still very difficult to reach the right person. At this stage, usually in a go-to-market, what we say is there is about 5% of key opinion leaders, or 3 to 5% key opinion leader in the world that really be top expert in the field of osteoporosis and so on. And then you will have about 15% of people that are really doctors want to be at the edge of the technology. They're really, early adopters, and they want to learn about it. They read a lot of articles, they attend conferences and so on. So those people have been reached fairly easily, and that's why we already have like a 2,500 device out there. Now the rest is not that easy to reach them for several reasons. Because they're not treating only osteoporosis, they're treating many other diseases, and osteoporosis is only a small portion of it. So it's not always easy for them to be up to date on every single disease. So we need to educate them. Moreover, as I said before, about 70% of the DEXA owner are radiologists. Radiologists will have no problem to buy such a software as long as referring doctors will ask for it. And the referring doctor, which could be rheumatologist, gynecologist, or practitioner, endocrinologist, and many other specialty, they will need to be aware of that. So it's like a catch-22. You say, well, I will buy it if I've been asked. Oh, I will ask about it if I know my radiology got it. So sometimes a bit like in between, it's not that easy. So that's why we've been setting up a strategy to try to let the radiologists aware of it, educate rheumatology, endocrinology, the others about the benefit of it by sharing publication and so on doing a webinar or different aspects. And also so that they can ask for the radiologists. The radiologists don't want to use their referring doctors, and then they will buy the software to offer the best service for them. But we should not downplay at all the patients, and the patients are having a more and more important role in the whole chain. Because if the patient feels that the doctor is not aware of certain development in the medical field, what they heard about, oh, my friends got this exam or this treatment or this and this, and your doctor is like been blocked 20 years ago, then that will not be very nice. That will not be very good for the doctors, even though I value the experience. But experience comes with age, but also with a constant learning, and we're learning every day. And that's why in the whole chain, from the patient to the doctors, the radiologists, referring doctors, and so on, everybody has his role to play. And that's very important that the patient can really ask the referring doctors, and the referring doctor will just ask the radiologist to get it, so that we can have more users. And for small companies, it's not easy to be, we are 20 people in the companies, in Medimaps, and 20 people, so we play on a network of distributors around the world, but still, it's a lot of effort for a very small startup.
Well, I'm hoping we can join in the mission to try to get this to be available to more patients and have, I'm sure many people listening to this will be asking their doctors. We'll try to get together some papers and some things, like a group that they can then share with their doctors to educate them and see if we can get more TBS available, because it's so useful.
Yeah,
we will all try to work with you and get TBS out to more people.
Well, I mean, the bottom line is, I strongly believe it's a really asset for the patient. And when we know that we were just running on one leg for so many years, and now we tell you you have two legs, why still running on one leg? So you need both just to be better, more stable, and everything. So that's really important if you can just leverage that.
We will do our best.
Sure you will.
How can we find facilities in the U.S. and Canada? Will there be a link to a web page on Medimaps, or so that people can easily see if there's a clinic that has it in their area?
Actually, yeah, there is two things. First of all, it's clearly available in US, Canada, and the rest of the world for most of it. So there is a link on the Medimaps website about find a clinic with TBS near you, or something like that. So it's not like a map that you can just click on it and have it, because there is some more and more regulatories around that, where we have to be careful the way we're sharing information. And every doctor who have TBS have to authorize us to do that. So what we do usually, when you click on where to find a TBS near you, you will enter a few information, first of all, about your email address, so that we can get back to you with an answer. And also the country and the state or the city where you are, so that we can just search around the nearest one near you and send an email to you with the coordinate, the detail of that site. Obviously, if there's no one around, but you have already a preferred radiologist or DEXA centers, one way or another, well, you can always share that information with us, and you can either download information to hand it over to that person, or we can contact that site and say, well, we have patients asking for that. would you be interested to have it? And we can work together just to make it happen so that you have TBS really around the corner for you guys.
Oh, that's great. Well, I'm sure a lot of people are wondering if TBS will be covered. You know, DEXA is covered at least every other year or so by medical insurance. Will TBS be included in that, or will they need to pay for it? And if so, do you have any idea what the cost will be?
Well, that's a tricky question.
Sorry.
It depends very much about the countries. So, for example, in Germany, we already have like a code associated to TBS. So it's not dedicated to TBS, but in which TBS can be fit in. And then the cost will be $50.
Oh, that's yeah.
Now,
That's
a lot of patients are paying already out of pocket themselves, and that vary from $30 to $150 or $200, depending where it is located in private or more clinic or whatever. So, but having said that, we're working very hard on different countries. So Germany, we have some kind of reimbursement. We're working also, we will have it very soon in Korea. It's on the way also in Japan, in France, Italy, it's a different country. But for US, let's cross the fingers because we've been working at that. The good and the bad thing is that the AMA, the CPT code commission found that there is no code that can be associated TBS. So we need a dedicated code for TBS. And then we've been working already for quite a while on that. And then been already surprised that we have already like almost 600 to 800,000 TBS being done in US per year as a number. So it's quite a large numbers. And then we've been with my colleague Shirley Horn from US, who's taking care of the US and globally actually. We've been attending a CPT code commission. We met people from incur, so that means the American College of Radiology, also meet people from endocrinology and rheumatology, and they decided, radiology, American College of Rheumatology decided to take all TBS to the commission themselves, teaming up with endocrinologists and rheumatologists. And the good thing is, actually, within the next week, so by end of June, we have a full finding. And then we're supposed to meet, hopefully, if will be no lockdown anymore, we'll be able to meet the CPT code commission end of September, beginning of October. And we're running for class 1 reimbursement, so that means covered directly for the basic insurance.
Great, great.
So hopefully by the end of the year, we'll have some good news. If not, we will have to wait a bit longer. But still, you know, when you consider how much time, how much money we spend for the haircut, or, you know, I mean, women more than men, but still, even for men, we're spending, you know, 25 or 30 bucks just to have a haircut done on a monthly basis. While the DEXA measurement and the TBS, it will be only once every 2 years, for example. So in that case, if it's better for your bone health, I think it's better just to consider what is good for you. As a medium and long-term run is much better.
Yeah. Also, $50 is, you know, the DEXA is several $100s, so $50 is, it may be a lot more affordable for some people. And I forgot to ask this earlier. I was hoping you could explain why TBS is especially important for smaller, shorter women. People taking glucocorticoids or aromatase inhibitors, or people with type 2 diabetes, chronic kidney disease, rheumatoid arthritis. I mean, there's definitely groups of people for whom spending that additional $50, if they have to, is really, really important. Can you talk just a little about that?
Oh, okay. I try to give a quick summary because also it's like a lot of disease to cover.
I know.
But the bottom line is, osteoporosis, the bone loss related to osteoporosis, related to aging and menopause, it is what we call primary osteoporosis. And that's what we talk about, combining the structure, the density will improve the fracture protection. But now, if the bone loss is related to a secondary cause, such as you taking some drugs, such like anti-aromatase for breast cancer, or if you take cortisone because you have rheumatoid arthritis or other disease or asthma or whatever, or if you have a certain disease like a diabetes or a chronic kidney disease or some others, all these will impact the bone in a completely different manner than just the natural aging and menopause. So those will have some side effect to some extent on the bone. So if I take the treatment, anti-aromatase and cortisone, they will be very good for certain things. That's why you have that. But they will have side effect, and those side effects will be a negative impact on the bone structure. So that's why if we have like certain treatment or certain disease, we know that the structure of the bone will be impacted more than in normal because of the secondary effect of certain treatment. And for disease, for example, if I take an example of type 2 diabetes, in type 2 diabetes, the patient tend to fracture more than normal. However, if we measure the density of the bone in those patients, the density is normal or even supranormal. So that's really problematic. You say, wow, how come my patient is fracturing more, but the density is very good? And actually, what's happened is the structure of the bone is being degraded by the disease more than the density itself. So in type 2 diabetes, we tend to have a normal density and a degraded structure in certain conditions. What I mean by certain condition, there is now several studies that have been demonstrated that if you are pre-diabetic, that means not really diagnosed, then it will be an early sign of pre-diabetes, will be a degradation of the structure of the bone.
Oh, interesting.
And if you have been diagnosed that your glycemic level is not yet controlled, then the structure will still be degraded. And as soon as you start to control for it, that means you maintain a level below 7.5, for example, then your glycemic level being controlled, after a while, the structure come back to normal. So it's interesting that in general, whether or not it's CKD, HIV, or some other disease and so on, there is some negative impact on the structure. And to some extent, the TBS, the structure, it's impacting the structure more than it impacts the density of it. The why for all disease, I'm not quite sure, and don't ask because I won't be able to answer that. Another important point that I forgot to mention is osteoarthritis. So you know that after the age of 60, 65, we start to have the density that will increase at the spine because of osteophyte or arthrosis in the posterior arch or different places in the spine. And that will just force or give the wrong impression that the density is good, while in fact it's just artifact. It's been shown by several studies now that the TBS is minimally impacted by osteophyte. So it's pretty often in patients, especially when you get older, that the density of the spine be forcefully elevated, while the TBS will give you better information, and that will be usually lower. And that's quite important as well.
Thank you very much. So is there, I know we've covered a lot of ground. Is there anything you think we missed that people should know, or do you think we've hit the high points here?
Well, that's we already have a lot of information here, but I think the global message that I will have is really the bottom line is that you have to have a better global image. You need both the density and the TBS, and also the clinical risk factors, because the TBS will help you to better identify more patients at risk, the one we're currently missed, and that's already a problem. It will help to fine-tune the therapeutic decision by having a better profile of the risk of the patient, and overall it will improve the management of the patient. And this is not a standalone technique. If we just do TBS alone, then it'd be like exactly like a BMD before. We're still running on one leg. We need the second one. Okay, so we need both just to make an enlightened decision. And the clinical risk factors is very important. And clinical risk factors, it's important because it's not just a matter of treatment or drugs. It's also a matter of lifestyle, about nutrition, about the type of food, if you're smoking, not smoking, alcohol, different things. And that's the whole things is not just a simple disease where you take an aspirin and it's done. It's something very complex, and complexity means not a simple solution. It's a multiple angle solution that need to be taken into account in order to preserve the bone health of our patients.
Thank you for that. In closing, I just want to say that I and all the people watching this really want to thank you for your pioneering work. We are all in your debt and greatly appreciate your taking the time to share with us today.
All right. Thank you very much. It was a pleasure.
All right.
Thank you. Bye.